as we move forward with this, the project, the functionality that we implement across the system, the campus, I'm sorry, will change over time. To give you a brief screenshot of sort of what a study trial looks like in Encore, this is the basic study creation process. And again, studies will start in Encore and then flow into Impact once they are reviewed and approved through the process. Some more specifics around how what they manage and how they manage some things within or can manage within Encore. Particularly, there's obviously a good reporting function, and there's effort tracking, which is something I think we'll focus more on once we get further down the road. And there's even a study information portal, which I think we will need to adapt to our method of doing things in the research, but is an obvious way to help spread the word around studies and participants, or to potential participants. As I mentioned, there's an electronic data capture part of the system as well. I don't think this is heavily utilized at this point, but it's definitely something we need to look at going farther out as we implement the system. And it is a nice way to capture discrete data around a study and then fold it into our larger data management ecosystem, which we'll show you in a little bit. This is the case report form design tool. So, one of the advantages is it's a fairly simple, what you see is what you get forms designer that's built into the existing templates and is easily connected to the existing studies that you have built in Encore. One of the things is, how well this exposes outward compared to something like Redcap is something we need to evaluate and get feedback on from the user community as we go forward. But certainly this is something that's out there now. To shift gears a bit and talk about power trials, one basic message I want to leave you with is that power trials is really just another part of Impact, right? It takes advantage of the same pieces of the system that we currently use in clinical care delivery, and all we're really doing with power trials is layering on top the study participants and the clinical services that we are going to provide through those studies. So one of the things one of the advantages that brings to us is that we don't have to retrain our nursing staff who are, intimately familiar with it from a clinical care services provisions to then we don't have to train our research nurses to use a different process than our clinical care nurses, because a lot of times those folks overlap. To give you a brief, walkthrough of how power trials looks, this is, the same screen in power trials that we saw in Encore. This is what a study would look like. One of the advantages that we have, which I'll show you in a bit, is that as we capture the demographics of the study, if you will, those demographics will follow the participants who are enrolled in that study, and you can actually build in contact information into the study so that when other clinical care providers need to contact the study team, this is where that data starts. As we walk through the process of enrolling a patient in a potential study, we can, for example, this is a sample patient, Milo Hart. We realize that he has a high hemoglobin, so we have a diagnosis of diabetes that we attach to this patient, and then we can use that information to suggest that protocol, that diabetes study protocol we saw a minute ago, and present to the clinician the opportunity to refer this patient to that study. Once that referral happens, the study team will get a notification and can then reach out to that patient directly to potentially enroll them in the study. Once the patient is on the study, a banner bar will show up indicating that that patient is on the study, and you can actually, that will become a hyperlink in which you can see a very condensed view of the contact information and a synopsis of the study from that link. You can also, down here, there's a clinical research tab, which I apologize, you probably can't read, but there's a clinical research tab that's also available from the menu bar to allow you to get more specific details about that study. So from the clinical care provider's perspective, there's a lot more information presented at the point of care about a patient of theirs who might or might, be enrolled in one or more studies. The other part of this is obviously the delivery of clinical services. So here is a view of the types of orderables that we can build into what's called a power plan in research. As you can see on the left-hand side, there's a study folder, and then underneath that you see the different visits that are a part of that study. In the pre-screening visit, which we're looking at now, we have a series of orderables that are we can order for that specific visit. And as you can see on the right-hand side here, the top one that's highlighted there, the CMP is to be billed to the study, and you can tell that because the study number is on the right-hand side. And then the lipid panel, which is standard of care, has no study built in there, and so you can delineate certain services that to be billed or in either to the study or to the standard of care patient's insurance.
Okay, thank you.
Could we ask a couple of questions?
Sure. Yes.
So, Jeff, it looks like with power trials, if someone's at the point, a provider is at the point of care, they can get notifications about whether a patient is eligible for recruitment.
Mm-hmm.
And if, let's say, I were that provider in this case, what would I do if I'm seeing Mr. or Mrs. Jones and such a notification comes? How might that work?
So back up a second. I apologize. I skipped the screen in the interest of time. But from here, you can right-click on that protocol name, and you will get a box that allows you to say, I want to refer this patient to the study. You can also say that the patient isn't suitable for the study if, for whatever reason, you as the care provider know that they shouldn't or wouldn't be eligible for that study. And you can communicate that as well to the study team. The study team has a separate interface that they review referred patients and recruitable patients to studies that I didn't show, but it's a grid model where they can see different potential participants who've been referred to them.
So then this might be viewed as a tool which will help recruitment?
Yes, I think so.
And how about patient safety? If one's not, let's say I'm in the ER, I'm wearing a different hat, and someone comes in, is it of value to know whether someone's on a special study or not?
Mm-hmm. I would think so. The on-study indicator here would tell you provide you the information that you not only know that they are on a study, but you could click the link and see what type of study it is and what, if any, contraindications there might be for emergency care or that sort of thing.
Thank you.
Questions here?
Does this imply that the patient will have to give the approval?
Yes.
Before anyone can have it showing the screen that the patient is available for any research study?
I think I understand your question correctly, so I'll answer it, and if I don't, come back at me. But once you have an approved study, you have to consent the patients as they are accrued to this, enrolled in the study. So at this point in the process, right, you have already consented the patient, hopefully appropriately, to allow them to participate.
Because how you say the provider will have access because it's going to light it up, going to show that the patient may qualify for some study.
Right.
So that's what you know. But if the patient doesn't want no one to know if he qualified for the study, there is something previous check that they say,
yes,
I allow my information to be considered for research.
Yes, so I apologize. We have in our treatment and consent form the ability for the patient to opt out of consideration for studies.
The way it would go at the point of care, I would be sitting there with a screen. I would see a patient might be eligible for study, probably because I've got a full clinic list. What I would do is turn to the patient and say, there may be a study for which it would be that you might be qualified for. Would you like to learn more? Correct. If the patient said yes, I think that gets pushed over to the study team at that point.
It's electronically captured. I think the mechanics of that are not it's more viewable from within the electronic health record than it is to the study team at this point.
But the patient has not consented to the study.
No, I'm not talking about consent, no. I'm talking about want to be approached to be offered research.
Sure. And then if you work, as you work at the point of care, as the provider, you can ask, you don't have to say, can I ask you about a study? You can offer the opportunity to learn more. The patient can say yes, the patient can say no. If they say yes, then you go one way. If they say no, you do something else.
Was there another question?
My team struggles with, on admitted patients, making sure that lab tests for clinical trials are charged to the research grant and not to a clinical account. Does this solve the problem?
Hopefully. I think it's intended to. How about that? The challenge with it's only as good as the information it gets from the study team, right? So one of the challenges with that is to make sure that the covered analysis is built in to the system properly, and that we can transmit that information across to the charges. But yeah, it's intended to.
Okay, thanks. Yep. All right. So I have a little diagram just to try to show how all these things fit together. So impact, electronic health record. We have Encore, a separate system, but those two systems talk to each other through power trials. So as Jeff mentioned, the study information goes into power trials, patients can be enrolled, and then enrollment goes back out to Encore. Data from Impact flows into the UAB Enterprise Clinical Data Warehouse, which has data from other sources as well, and then data from there can flow into I2B2. Which is a separate repository where the warehouse is, you access that with the help of a human analyst who will actually execute queries for you. I2B2 is a self-service application. And then case report forms captured in Encore can go into, they can go into Impact if appropriate, they can go into the warehouse, or they can just go into I2B2 depending on where you feel it's appropriate. Okay. So I2B2, I just want to mention one of the accomplishments that we've had this year is to position I2B2 as a repository of data that can be used without having to get IRB oversight for every time you want to use it. So the I2B2 repository is accessed in a de-identified way that is deemed to be non-involving human subjects. So it's you can get summary data as non-involving human subjects. If you want detailed, de-identified data, then that's considered exempt from IRB oversight. So you have to put some information into the system, as Matt will show you, to tell the system why what you're doing with the data. But otherwise, it's not. You don't have to go to the IRB and wait for approval to do that. So it's self-service. You sit down, do your query. If you don't like the result, do another query, and then download your data. Say, oh, I need to get different data. You can do that without having to wait a week or whatever it takes for the IRB to be able to respond to your query. So the bottom line is, with the right authorizations, which Matt will talk about, you can access the data in real time without individual IRB approval every time you want to do a question. So with that, I'm going to turn it over to Matt Wyatt to walk you through I2B2.
So I2B2, at its basic intent, is intended to provide data in a few different ways. So I'll walk through sort of those ways. But from a big picture perspective, it is intended to be a self-service tool. It's available for any UAB faculty and staff, as long as you go through the right process of requesting access and have all the right training and sign the right documents, etc. It's for the most part, it is intended to satisfy from pre-research all the way through secondary analysis research and even recruitment for prospective clinical studies. So like Dr. Smino said, it allows you to download data related to UAB patients for feasibility assessment, proposed enrollment for clinical studies, considering eligibility criteria. You can also do hypothesis exploration. So it satisfies both, do we have the patient population to participate in this existing study, or let me explore information to determine what might be reasonable things to approach for research. I'll go back to that. It's intended to be very easy to use. It is a drag and drop user interface that will provide information, both summary data and the ability to download detailed data. And it is available currently. So the first use I'll talk about is the summary data for feasibility assessment, cohort analysis, proposed enrollment. So this is the main I2B2 screen. It is the concepts that you see on the left-hand side. And so is there a pointer on here somewhere? I really can't see where that is. So allergies, diagnoses, labs, medications, procedures, visits, patients, vitals. So you can navigate those various concepts. As you can see, there's a pretty good amount of content in there. Those counts are basically the amount of clinical content. You can either navigate those things or do specific searches for ICD-9 codes, ICD-10 codes, CPT, for multi-medication categories, for specific medications, specific lab tests, etc. And you drag concepts either one at a time or in folders. As you can see here, we have querying the full folder for diseases of the eye and Nexa. This particular query is African-American females that have one of the diagnoses that fall within that category. And the answer here is that we have about 7,500 patients that meet those criteria. So you can get very detailed combinations. So if you want to do African-American or Hispanic, or African-American and white, no problem. Males, females, any combination, you can get to very complex logical queries with as many of these groups as you want. Some of the particular more details, so you can say patients on anti-diabetic agents in a particular time frame. The lower right-hand side, so you can say has a BMI of less than whatever number you would like to put in. You can limit to patients who have a particular piece of documentation, or as in the no-known allergies, do not have a particular piece of documentation. So sorry about the double negative, but this would be no documentation of no known allergies. You can do very specific lab result queries, so hemoglobin A1C greater than 7. You can also do the query in the upper left-hand corner. You can say, give me all of the people on an anti-diabetic agent and who have a hemoglobin A1C over 7 independently of one another. Or you can say, give me people who have a documentation of an anti-diabetic agent and a hemoglobin A1C over 7 on the same encounter. So it lets you do much more detailed queries. And this is just a sampling. So, and what that gives you basically is summary data. You can do a single count, you can do a distribution of age, race, gender, etc. But if you want more detailed data than that, either for a more specific question of feasibility assessment or for secondary analysis, UAB has built a plugin to I2B to download data and to request additional consultation if it's something that you can get from I2B2. So it's a pretty simple interface. You say what kind of data you want. You can either download summary data. So the top example is basically the top diagnoses. So the 69 of the patients, which is 87% of this patient set, has CLL without mention of remission. And so you can get summary data that will show you basically the distribution of other clinical criteria for your particular patient set, or detailed patient and visit level data, like the bottom example, that will show you the diagnoses for every visit for every patient. So you can look for things like the existence of these 3 diagnoses on the same visit, or this medication and this diagnosis on the same visit, or this lab result before, on an encounter before this diagnosis, etc. So the last thing is, what if that still doesn't meet your needs? What if I2B2 doesn't have a piece of information that you're interested in? What if you need contact information because you say, this is the perfect patient set for me. It says I have 150. Now I want to go recruit those people. And the IRB says you may. There's a request process for getting additional information. And this really could be very flexible. It could be as easy as, I don't know what I want, call me. Ideally, that's not the best starting point. Or here's my macro level patient set. I would like to refine that and get more detail. Or this is my patient set and it's too big for me to download here, send it to me. Or this is my patient set, I need contact information, put your IRB protocol number in and you can get contact information. So I think the big picture is, if you would like information from the enterprise data warehouse, I2B2 is a self-service tool for some subset of that to basically satisfy any of those needs. And if it's not, call us or submit a request for help via I2B2 and we can help you with that. Let's see if my pictures. What's in I2B2? So here's the existing data in I2B2. Here are some things that are sort of on the priority list of things to incorporate into I2B2, but I think probably the most important thing on there is at the bottom right-hand side that says Other. Because effectively, if it is a priority for UAB and would support the research community at UAB, we can put it in I2B2. If we have the data and it's on medical record numbers and we say we want it and it's something that's very important, it'll go to the top of the list and it can be put into I2B2. The next thing is Redcap. So Jeff described one of the functions of Encore being electronic case report forms. And depending on where in the institution you're positioned, whether it's clinical research in the process of clinical operations versus things that may be more wholly on the research side, even potentially on people who do not have UAB medical record numbers, Redcap is an option for that. It's something that exists here at UAB. It allows you to do research data capture really in a pretty big variety of ways. You can configure it to collect just about any kind of data you want. It can support multi-user capability, so more than one person can interact with it. It can do field level validation, conditional logic, so you only ask relevant questions if you ask, depending on the answer to previous questions, etc. It has inherent data support for exporting things to SAS and R, Stata, etc. And it is supported in partnership with the CCTS and the Department of Medicine. So there's a address there to get information on the Department of Medicine instance of Redcap that they provide as a service to anyone on campus. And my picture is not on there. So yes, any questions? Yes.
Two questions. You talked about what you can do. My question may be covered in the training material before you get access is what you should do. So is it described in terms of what you should and shouldn't do in ways of analysis and like trying to do publications off of data that you're not telling anyone about?
Yes.
Or that sort of thing?
So this is positioned very specifically for the data that you can actually get directly from I2B2 without a consultation, without an IRB protocol specifically. Any summary information is, and actually let me rewind. In order to get access to I2B2 at all, you have to have completed IRB training, human subjects protection training, HIPAA training, and acknowledged the guidelines for use of limited data sets. So there is a description of what is appropriate use of limited data sets from UAB. And so that lays out in pretty good detail what is acceptable use. And that's something in the UAB learning management system, faculty and staff learning system. And so that lays out exactly what the acceptable use from UAV policy perspective is for limited data sets. There are some reminders along the way that this is information that you are pulling in. Some things like when you are downloading a data set, it will ask you who your collaborators are, and they have to have had IRB training as well. So I think, but from a big picture perspective, any summary data that you get is acceptable for use basically however you would like, according to just general UAV practice. For proposed enrollment, for feasibility assessment, for submitting information, for summary data, for research proposal. For the limited data set or the actual patient level data set, it is, like Dr. Cimino said, it is not considered human subjects research because it is de-identified or specifically HIPAA limited data set.
I understand that. I guess I didn't phrase my question correctly. I'm envisioning a scenario where two separate people here at UAB do what they need to do to get access. Maybe they have a similar research question. Maybe they do a similar analysis and they submit it to different journals for publication. Then they'll get into a fight over whose idea was it first. How is that potential advantage?
I would say that's above my pay grade.
That wouldn't now.
Managed at this level.
Well, but you give people a gun, they might shoot themselves. So I guess that's the thing.
I mean, people use publicly available data sets all the time.
Well, but a lot of the data use agreements, even the publicly available ones, is that you register your question with them, and so you've kind of got a stake in the ground. You have an option to say, okay, I thought of it first, even if you didn't actually think of it first. You can say I registered it first. So I just am concerned that within UAB, there may be a potential for UAB people to fight amongst themselves over this powerful tool. I like the idea, but I hate for it to get ugly.
I would welcome the opportunity to have multiple people publishing papers for my 2B2 data here. So we'll sort out who wants.
Well, what a lot of the curated data sets have now is that you register your research question. They say, okay, we agree that this is a good one, and go forth and conquer. You may never do anything with it. You may never publish on it. But that another person who comes along, maybe a medical student, says, I want to do this analysis. If it's registered, they can say, oh, someone's already done it. Maybe they've already saved me a lot of time.
So I think that's typically done with research data sets, that somebody has a research data set and they're controlling the use of that. But there are a lot of data sets that nobody's controlling. Every medical records department in the country is subject to these kinds of uses, and nobody's monitoring how they're used. Medicare data sets are freely available. So, there's just, we could try to impose a national system for that. I think this happens all the time, and it doesn't seem like such a huge problem. I think the bigger problem is that if somebody publishes a study where they've drawn data from a data set, and they said, for instance, somebody is doing a prospective study on patients with a certain disease and says, oh, they seem to have these characteristics, and then somebody else comes along and says, oh, that was really good, you only have 10 patients. I'm going to go into ItoTo and I'm going to find 100 patients and I'm going to publish that. You may inadvertently include the 10 patients that were already there. So that's a problem as well. And when I was at NIH, we had some policies around how you would acknowledge where the data came from so that it would be at least traceable that there was potential for that.
Well, my other question is, I assume this data goes back to when impact was put online, or does impact contain data that has been inputted from paper charts into it?
And it goes back to when impact was brought online. We did carry forward some documents, if you will, from the old system, but they're not in discrete form, so they wouldn't appear in warehouses.
Impact went online, right?
When the 10 and the edition side.
I just think that it might be nice to have some guidelines about reporting, like the date range of the data and the query that you did, so that again, it's reproducible and it's clear, so that I later as a meta-analyst don't include the same pool of people twice in my study and those kind of things.
Okay.
That's called duplication, not replication.
So,
And that's not good in that
Jay, go ahead.
Yeah, so I wonder if you planning to include additional database, for example, biobanking, cancer registry, to make it available so that
Yes. Short answer is yes. There's lots of stuff that we'll be bringing in. Biobank we'll have, we'll have, for instance, the fact that there are specimens available and how you'll be able to get to them, cross registration and cancer registry. Do we have the cancer registry data in there now?
We have cancer registry data in there now. It is, we may be restructuring how you navigate the cancer registry data now, so it's not available for really general public use, but we actually have loaded the cancer registry data into ItoTo.
All right, I want to move on to give James Woolley. He's going to talk to us about some of the systems he has available for us.
So speaking about things we want to get like online, this is sort of patient-reported outcomes and how we can use them. So I'm going to talk about two tools specifically. And again, this is sort of captured directly from patients, and one of them is at the point of care, and one of them is from folks when they're home and outside of the immediate arms of the health system. So the first system is this Pro system. This is a web-based platform that we built a couple years back, and the purpose is to capture patient-reported outcomes information in clinical care settings. Some key part of it is that it's got an expandable instrument library. At this point, with several partners, we've gone up to over 40 validated instruments that are in the literature that are basically specific questionnaires to quantify some facet of health, like depression or quality of life, or some severity score for a specific illness. There's several in arthritis and gout, different things like that that we've built in there. And there's some other examples up there. So when we work with a partner clinic, we basically start seeing if they need some instruments that are already in our library to sort of build their clinic-specific set of instruments, or if we need to add new instruments to it. Both paths are available. These are some of the partner clinics that we've been having, and some of these are sort of clinics that are in use. I think you can see that we've done 52,249 signs and symptoms at the 1970 clinic since 2006 or so, 2007. I have happily not drawn an outpatient signs and symptoms in 11 years. It's been wonderful not to have to ask those questions. I just sign a sheet. Our social services folks and our palliative care folks are in a couple of thousand patient encounters. You can see that our viral hepatitis clinic is really expanded broad. This is a clinic that's about a year and a half old. It's already up to 1,200 encounters, and you see several other things. These are actually research studies with iEngage and VA2C that we're using this platform to put information out to participants. And the pediatric neurosurgeons are our latest partner with Brandon Roque in pediatric neurosurgery, and they're using this in children's in one of their outpatient spina bifida clinic. So just to give you an idea, here is a palliative care clinic. It's at 1917, and the conversation we have with someone is, first it's the selection of specific instruments. In this example, they've chosen instruments that measure symptoms around, just general symptoms of how folks are feeling, specifically a survey about pain symptoms, anxiety, quality of life, and depression. Those were their selected instruments. The next is sort of the sequence in which they want to have it, and to see if there's any skip logic that they want among the instruments. These folks did want some skip logic. They wanted a general symptom survey, and if the pain was improved, they wanted to skip the specific pain assessment. But if the pain was the same or it was worse, then they would go ahead and get a specific pain assessment to have more granular data to drill down to in that encounter, and to have more granular data available for subsequent research uses. So this is the internal logic. The frequency, a clinic would say, I want to know about people's anxiety twice a year. It's not that relevant to my practice, but it's relevant enough that I want to capture it that often. Something like pain in the pain clinic has to be captured every encounter. If they come in every week, you're going to ask those pain questions every time. And something like a depression assessment might be different. So for all of these domains, there's a different frequency that's assigned. The other thing we do are alerts. So in this specific one, this pain clinic wanted some alerts. If there was intimate partner violence that was detected or suicidal ideation, they want alerts to go to the pages of the right people in the clinic to go intervene. And then that sort of sets off another stream of data capture through what's the risk for this, the imminent risk for this person, and it starts a process so that that person can receive care. And they're also study enrollment. So this has transformed our clinic in the sense that we used to have study coordinators for multiple studies in clinic in a live clinical setting with a lot of moving parts. Right now, those folks can go and monitor this completion of all these surveys, and they can get alerted specifically with the location of the client that meets their study criteria if the enrollment criteria is through a patient-reported outcome. So we've had great success with depression studies and severity of pain studies and things like that, where we basically get your study coordinator, keep them working at their terminal. We will let you know when someone meets those criteria. And it really makes enrollment facile and sort of in real time. One session, multiple users is something we've added for the spina bifida clinic. This was an interesting challenge where, there's one session, but there's a patient who's incapacitated. So here it's often someone with spina bifida who cannot care for themselves independently. So a caregiver comes in, and we learned the concept of caregiver with them because I said, oh, that's just the first person. They said, no, that might be the parent that doesn't live with that individual, or that might be someone who's taking them to clinic, but is not the caregiver. So I need to know specifically that it's the caregiver. So there's some questions. Once you determine you spend a certain amount of time with that individual, then you're given a specific assessment to measure the effects of caregiver fatigue. So we can imagine this being used in cancer settings where there's a caregiver or a rehab setting, types of things where there's more than one. It's sort of, there's an illness that has an impact creator that involves many people in that person's life. So you can ask them questions specifically. Once they complete that set, they're kind of asked, okay, is the person able to do these questions independently? And if they're able to do them independently, they can pass over the iPad at this point, or whatever tablet you're using, and then they can answer those specific questions. And we'll be able to tie all that in the back end to the same session and the same individual, even though different people used it. So this has sort of been an interesting thing. So that's, I think, in terms of that Patient-Reported Outcomes tool. And all these data, we try to tie this and use some IDX identifiers so that we use things that are in the health system to make this data easy to export and easy to connect with some of the other things that are available. In the future, we'd love to sort of bring it into the fold, maybe tie to B2 and so forth, so that we could all have access to these tools. The next system I want to show you here is, this is now getting outside of the clinical setting. We've given a lot of thought to the fact that a lot of the important things that happen to folks happen outside of the immediate care setting. So we wanted to have a way to reach out to them. And we created this tool. This is with Jeff Curtis in rheumatology. And we've created this thing called RootPro. And basically the 4 pillars of the design are that we want to empower an individual user to capture their own data. We want to empower that user to manipulate and share their data as they please. And we want them to empower that user to be able to fight whatever chronic illness they're facing through the opportunity to do research. And we also want them to educate and connect them to a community. Because the different thing here is that in the software we've done before, everybody is captive in the clinical setting. Now I'm competing with them at their house when they have like the national championship basketball game to watch. That was amazing. The last 2 last-second shots. I'm sorry, I'm not going to fill out your survey when I'm watching North Carolina and Villanova. That's just not going to happen. But you're competing with Netflix or the other things going on in their life, but now you have to get in there. So you have to give them a little bit more utility out of the tool than just, hey, why don't you participate in my research study? How can I use this differently? And how can I engage from it? So we're able to send notifications to people specifically whenever it's time to do your survey. We're able to sort of use this as a platform where we'll do some queries on the back end and say, I want females with this age group on these medications, and sort of put a research opportunity specifically to that group. If they go into that group, they do an informed consent loop, and then they collect their information. But all the information is transparent and visible to them. Here you see information on several assessments on the left that user has either agreed to participate in that research or they've added on their own. And on the right, you can see them graph their results over time. They can also do some drop downs and sort of do it by medication. I want to know what my pain has done since I started this new medication. Then that graph will reflect on this period of time you're on this medicine and on this period of time you were not, so that you can really see the impact on these patient-reported outcomes measures. It's transparent to the user, but we're pushing out pro measures. We're using promise measures from the NIH. And we're also working some interesting assessments that use the sensors in the phone to measure how far you walk and do sort of physical assessments or performance-based metrics. Here's sort of the mock-up of what our Opportunity Central page looks like. And keep in mind that here we reach specifically to a user and say, hey, we have a research opportunity for you if you would choose to participate. So this is sort of how we would present the data on the one side of your screen. This is a specific opportunity we have up where we are working with this commercial lab where you can go ahead, and this is a test specifically for rheumatoid arthritis disease severity. And if you have used that test, you can go ahead and sign in, and we'll go ahead and then use another service to authenticate that it's you. Because, you know, my kid can get into my phone, but my kid can't answer 5 questions about where was my address when I was 13 years old. They mine publicly available databases. They ask you specific questions about your life. The service is called ideology, so you can authenticate that. Yes, you indeed are the owner of this device. And if you pass that hurdle, then we go ahead and bring in your lab data. So now the individual doesn't have to go to the health system. They don't have to go to necessarily the patient record to get this small period of data, because we go directly to the laboratory and get it for them. So those are two things, and as you can see, that's a very flexible research platform, and the idea is that we can start capturing data from people, both in clinical settings that they self-report or in their homes that they would self-report as well.
See if there's questions.
Any questions?
Sorry. We have some people joining us online too, so when you're done, you can ask them if they'd like to ask.
Okay, so I heard last year Apple just came up with a software suite API that allows capture of those data from the mobile phone. I wonder if this is integrated with that, or what's the...
So we are in fact integrated with HealthKit, and here in our next sprint we're going to integrate with something called OpenMHealth, which is an open API that allows us to bring in data from the major like Fitbits and fuel bands of a lot of the major devices. You can imagine that thinking of how those data are going to look is something we're still thinking about a lot. But yes, HealthKit data and mobile sensor data are going to be brought in as well.
How do people input the data? Are they using, is it a piece of paper that's being scanned, or are they using iPads?
They're using their phones, whatever device they have.
Well, what I'm talking about when you're in clinic with,
The Pro system.
Yes.
So typically we like to use touchscreens. I think keyboard and mouse is much more of a barrier. We've also found that a lot of our patients that we thought could read actually can't read at the level we thought.
Yes.
But touchscreens seem to take a lot of that anxiety away. So we either put touchscreens on the wall, or other clinics have used sort of tablets. I prefer touchscreens that are screwed onto the wall because I don't want to keep track of tablets. But plenty of people keep track of tablets and they're fine. My patients are a little bit more creative, so I've had more, like a big computer tower disappear from my waiting room. So no tablets for me.
There were questions at home, Brian?
Just, you can ask.
Any questions from the folks lurking on the internet? I think one of my daughters is out there. You have a question?
Do you want to ask?
Thanks, everybody. I'm tapping in now. So just wanted to point out some of these arrows are still under development. The data from Pro to get into Impact or into the enterprise warehouse or to ItoB2, those are still in planning. And the idea is to be able to put them where appropriate for patient care, to have them go into Impact, and then they would flow all the way down into ItoB2. But where they might be something that you wouldn't want to show up as part of the patient record, then it might go into the warehouse. And if it was something that you felt like you didn't want other people accessing your research data through the warehouse, you could do just have it in ItoB2.
So maybe I missed something, but what of all this is already available so we can go and try?
Everything is, so Power Trials and Encore are what, I mean.
Encore is live in the Cancer Center.
Encore is live in the Cancer Center.
Coming soon to a
JT15, it's live on JT15.
Okay. Power Trials is not.
Yeah, May.
May, okay. The Enterprise Data Warehouse is up and running now and has a fairly good high proportion of the data that's in Impact. And ItoB2 is up and running now. You can get access to it via the website. So that you've got to fill out a little form, and then you'll get access tomorrow if you want.
So if there is a cost, because I'm thinking in feasibility questionnaire for research, I do work in research. If we want to ask for a data set of people that may qualify for a study, if there is a charge for that?
So at the moment, there is no charge for data. First of all, you can get your own data sets from ItoB2, so there's no charge for that. And you can get, we have analysts that can do the queries against the warehouse. There's also no charge for that. But that's a limited resource, and it's often takes time to get the data that way. So we encourage people to go try ItoB2 first, see if it gets what you want. If you've created a data set there and want more data on the same patients, that makes it a lot easier to get it out of Impact too. So we encourage people to go that route. But no charge for any of this.
Thank you.
Okay. So a couple other resources I want to mention, and these are in process. Shrine and Trinetics, and these are linked to our ItoB2, but they're also linked to two other ItoB2 networks. The Shrine is through our Southeast Shrine Network. Consists, and I always stumble over this, Emory University, Medical University of South Carolina, University of Arkansas, and UAB together form the Southeast Shrine Network. And you can do distributed queries with one ItoB2 instance and get summary data from all these different sites. And then Trinetics is a commercial enterprise that was set up by pharmaceutical companies who want to be able to find out which institutes have lots of patients that might be eligible for their study. So they can query individual institutions to find out how many patients they have to meet whatever the enrollment criteria are. But as one of those institutions, we're able to then query other institutions on the network, and we can pull those data not only to see what the numbers are, we can actually use them for research purposes if we want. Again, it's only summary data, which is challenging for research purposes, but it's there. Okay, so those are all the big pieces. Everybody comes to this, I think, with a different idea. That's one of the problems, or maybe the opportunities in translational research. Everybody does translational research. Everybody takes some finding from some level of knowledge and takes it to the next level. And so we're all translational researchers. So everybody has a different idea of what they want to do. So if you want to estimate potential cohort for a clinical trial, you can use I2B2. If that doesn't work, you can come and use the data warehouse. If you want to actually find subjects for a study, you want to contact them, try to enroll them, again, I2B2 in the data warehouse will do that for you. If you're going to set up a clinical trial that's going to be run here at UAB, then Encore and Power Trials are the tools you want to use. If you want to enroll subjects in your study, Power Trials is the tool you'll use for that. You want to capture data, some data are captured in Impact. You collect your laboratory results, you put in your progress notes and what have you, so it's collected in Impact. Also in Encore, Redcap, and Pro also have data capture forms. If you want to pull data from your own trial, you can do that. You'll be able to do that from I2B2. We don't have that set up yet because we don't have the identities of who's on what trial in I2B2. But eventually, one of the queries you'll do is say, find me all the people in this trial, and now get me all these data. And of course, you'll only be able to pull data for your own trial in identified form, but you'll be able to do it yourself in I2B2. And if you want to reuse the data to answer new questions, again, you can use I2B2, you can use Shrine, you can use Trinetics, you can use the warehouse as well, but these are the self-service applications that you have available. Okay, let me stop there and just see questions. Somebody wants to do something that's not on the list.
Where do you sign up for I2B2?
I'll show you the instructions. Andy, did you have a question?
No.
Oh, I saw your hand move.
That's right.
Oh, sorry. Okay.
Jim,
Yes.
There's a multi-site trial. Let's say UAB is lead. What kind of tool can one use for that?
So you could pull data from, if you pull the data from multiple sites in some format, you could load them into Redcap, for instance, and put them all into Redcap and use the tools that are there. Could you put them into I2B2? So I don't know that we've talked about that, but you could certainly bring those patients' data into I2B2. You'd have to assign them a different identifier so you knew they were from another institution, didn't mix them up with our own medical records, but that would be doable. I don't think we have a plan to do that directly. Were you thinking of something else?
And if there were a clinical trial, Encore, I think, is a web access, if I'm not, is it a web access?
Mm-hmm. Absolutely.
And so as long as people have the right authentication, it doesn't make any difference where their desk is.
That's true.
Is
Right.
that correct?
Right.
So you
It
could
is, there are
actually,
some organizational permissions issues to work about a multi-site trial, but once you get past all that, you can use Encore to manage your clinical trial, whether it's just on some premises here or across a number of.
I mean, you can also, if you want to use the Shrine network, if we expand it into different partnerships, if you want to query against 5 different institutions, there are other Shrine networks other than just ours. We could internetwork.
Matt, did you have?
Redcap is currently used for multi-center studies, either as other people can log into our instance of Redcap and complete data entry for multi-center trials, or models where people use Redcap at multiple institutions and then just combine it with that.
Okay. All right, so hopefully you got a sense of the systems that we have available. Hopefully you understand how you can use I2B2 to get patient data. And the last thing I haven't done yet was to help you find your way through the clinical informatics pages. So this is Research Commons, the Research Commons page, and I'm going to show you we've redesigned the clinical informatics, mostly the clinical informatics pages within. Let's see, is this mouse working? Yeah, okay. So these are, I don't think these pages are live yet, but they will be as soon as we get a chance to actually proofread them. Wendy's been going crazy today building all these pages for me. So let's see if this is going to work. Let's try that again. Security alert. Help protect me. Don't protect me. Okay, let's see if this is going to work. I think I was a little hasty. There we go. Okay. So here's the research comments page. And if we scroll down, and we'll find the informatics button. And now we have the informatics page. And there's here we have services and tools. And we've got two sets. We've got the bioinformatics, which we haven't talked about today, and we've got clinical informatics services. So we click on that, takes us to clinical informatics, and we've got 3 tabs here. The first is self-service access to clinical data. The second is clinical data enterprise warehouse, and the third is study design and execution. I'll do that one first. It's fairly simple. It's basically a recap of what we looked at today, and it's got a little link that says, if you want more information, contact me. I think we're going to put Jeff's email address in there. But for now, we put mine in there. Clinical data, clinical enterprise warehouse, also fairly simple. Basically, if you want data from that, you fill out a clinical data request form. And so you go and fill out that form, and we will be back in touch. And then the last one is, and this is where we'll give you the instructions on I2B2. So self-service access to clinical data, and there's some verbiage there about what you want to do with it, but then there's a link here to instructions on getting to I2B2. So basically, the first thing you have to do, if you are not an NIH investigator, you have to get permission from your supervisor to do so. And so basically, have your supervisor send an email to Matt Wyatt to say this person is allowed to do it. If you are an investigator, and we already know that we assume that you're doing research and allowed to do this. The second thing you have to do is you go into the learning management system, and you log in there, and you search for the I2B2 or limited data set course. It's a learning management system. So as a course, basically the course, you take a test, and the test has one answer question, which is, do you agree to this data use agreement? And if you say yes, then the learning management system now has registered that you passed this course. You also have to take all the human subjects training that would be required anyway of an investigator here. And once you've done all that, then you can go to I2B2 and you can log in. And we have the login here. Login address, login link there. So all of that stuff now is in one place on the Research Commons website. So we went over a little bit. Questions?
How do you use your login?
I'm sorry, what?
How are you going to be the login? Do you use your Blazer?
It's a Blazer ID, yeah. Sorry.
I'm thrilled to see you did some pediatric neurosurgery work, but is there any plan to try and integrate children's EMR into this?
I did some pediatric what?
I'm from pediatrics,
Oh,
so it's thrilled to see neurosurgery. I've heard some rumors of this, but I would love to expand this to child neurology. But we can't even get stuff out of our own EMR.
So,
The streets will tell you.
Yeah, we provide the data to Brandon whenever he needs it. So I think you won't have to worry about getting access to your data. And I think we're very eager to work with some folks. We've been talking with Teresa Magruder for asthma, and I think that I'm forgetting the name of the person who runs the neurologic musculoskeletal disease, like
Randy Cron, Tim Buchelman.
But
one of those guys.
Yeah, one of those guys. But anyway, so yeah, basically, if you want to do it in your clinic and everything, Rodney will have.
Yeah, there's a plan.
For Pro.
There's a plan in the works to pull the data from the EHR at Children's Hospital and put it into an I2B2 instance. Once you do that, then you could query across both ours and theirs, and we could merge the data so that you could actually get longitudinal data. If we can map the medical records to patients that are born here, treated there, come back here, you'd have longitudinal records across all those experiences.
One last question. Is anybody doing questionnaires of adverse childhood experiences? Does that ring a bell with anybody?
No, I'm not aware of anybody doing that.
I don't know. Okay, other questions? Okay, well, thank you for your attention, and we'll be available for questions that might come up online afterwards. And thank you for everybody.